Hello and welcome. Tonight we are going to be talking about insights and the role of ultrasound guided injections. And this is a webinar we're doing in collaboration with IBSA UK and Citius Retreats. I'm Andy Thomas, founder and director of PhysiQuip. And at PhysiQuip, what we're really passionate about is we're always looking at ways in which we can help educate and ultimately develop both clinicians and businesses. So tonight's going to be a really good collaboration with two partners. So we're joined to have a presentation from Dr. George Bownes, who's sports and exercise medicine consultant at both Citius, which is a really exciting new brand. I love it. I definitely want to go on one of these retreats, as well as the very well-established Fortius clinic. George, how are you doing?
Very good, thank you. Thanks for having me. Thanks for coming along, everyone. Hope you're all having a nice evening out there.
Yeah, a little bit wet here, but anyway. And then later on, we're going to be joined by Kirsty Walker, who's an advanced physiotherapy practitioner. She's also clinical account manager at IBSA UK, which is a Swiss multinational pharmaceutical company. So I shall now hand over to you, George, and we'll let you crack on with your presentation.
Thanks very much, Andy, and thank you everyone for joining. Hope you can hear okay, and there's always a recording for later afterwards. So what I've been asked to talk about today is ultrasound guided injections and how you can restore normal function to a joint which has either had an injury or has arthritis. So first of all, we'll just talk about what a normal joint looks like, and then talk about the changes that occur with age, but also with injury, how ultrasound can help with the assessment of those joints, how hyaluronic acids can help with recovery, rehabilitation, and all with management, and how the newer products are different to the more traditional ones and how that can aid function. We'll talk a little bit about my experience of it, and then in terms of next steps. And then at the end, Andy's going to come back around and we'll have more of a Q&A. So what is hyaluronic acid? Well, it's a natural product. It's in all synovial joints. And primarily the function of it is to lubricate the joint, to nourish the joint, and to act as a shock absorption. So therefore protecting the joint. And these unique characteristics are important as we go through the story of hyaluronic acid with arthritis and injury. So it's important to understand that the function changes depending on the load. So that's what makes it what's called a non-Newtonian fluid. Okay. So if you look at the graph here, and thank you to the guys at IBSA who've provided me with some of these graphics for you today. If you look on the left, you can see the gentleman sitting in a chair. So at that level, there's low force through the joint. If we use the knees as an example, just because it's a large synovial joint that's commonly lacking in hyaluronic acid, you can see that there's no load through the joint and the hyaluronic acid acts as a lubricant. Now, as you increase load, going from sitting to standing to walking to running, which is what you have on the right-hand side, the red line shows this change where it then becomes more of a shock absorber. And you can see there's an inflection point in the middle there. What you also find is that lubrication within all synovial joints starts to change from around about the mid-30s. And then as joint degradation continues, arthritis takes over, you get a continuation of this where you're losing the shock absorption, but you're also losing the lubrication. And that's what this graph here, or this graphic is trying to demonstrate. So cartilage is destroyed over time by changes within it due to load, inflammatory mediators, and often in many cases, injury. And as that happens, you get, as many of us will know, narrowing of the joint space, articular cartilage thinning and then loss, osteophyte formation, and inflammation of the synovial membrane. So on the right there, you've got all the reds, And in the normal side, you've got the blues there where you've got good synovial fluid, you've got smooth cartilage surfaces, you've got a good joint space between the bones of the joint. The synovial membrane is very smooth and not inflamed. And these are things that we commonly see in clinic. I'm sure that all of you will be fully aware of these changes. Now, what happens on the right-hand side, if you've got these degenerative changes, is that joint, that capsule, is not so compliant, and therefore there's pain and then there's stiffness, which you don't get in a normal joint. Now, this is also the same as what happens with an injury. So if you imagine a knee, and we'll reflect back to the knee simply because there's so many things that can happen to it, and it's such a common presentation. So if that was an acute collateral or cruciate ligament injury, or even just a jarring of a joint, you start to get some of these changes, but particularly the more instant inflammatory ones, such as the synovial membrane becoming inflamed. And that leads to joint space narrowing. So if we then think about arthritic change, and again, thanks to the IBSA guys for these slides, but in the UK, currently, around about 3.2 million people have arthritic change within their hip, and around just under 5.5 million have arthritic change around their knee. The impact of that is that often people with established arthritic change, particularly in these two joints, will be less mobile. And in doing so, that then increases your chances of developing cardiovascular disease, diabetes, and other significant comorbidities because of the loss of function. You're also less likely to be employed potentially, and therefore there's a bigger burden on society. And it's thought that people living with 4 or more chronic health conditions is looking to nearly double in what is only just over 10 years from now, which is a huge increase, and therefore the demand on the system. So why use ultrasound for either injury or arthritic assessment? So ultrasound is relatively freely available. The machines are quite small, as is the case of this one demonstrated here. It's the sort of size of a laptop. The accuracy is high for what we're looking at, which is, as we were showing on the previous slide, you're looking for joint space loss, inflammation, and signs of general swelling. It's non-invasive, so therefore, particularly with aging populations, that's quite helpful. It's something you can do in the clinic. You don't have to bring people back, and therefore it's reproducible. It's also dynamic. As you can see in the picture there, assessing a shoulder, but you can get the patient to move the shoulder, even with, more expensive assessments like an MRI. It's still a static image, so there's definite advantage of that. And I'm sure you've all seen ultrasound imaging before. And as with anything, it's all about training and the competency of the person holding the probe and then interpreting the image. But you do get to interpret things instantly. And it's quite helpful with patients as well, because you can talk them through what you're seeing, explaining your management plan, particularly if we're talking about an injury. Does someone need to be going into a brace? Are we offloading that joint? In the case of a knee, we talk about cruciate collateral ligaments, for example. Does further investigation need to occur? And then when it comes to the next level of intervention, we'll come back to the added advantage that ultrasound gives in injection therapies. So that's just a little video showing you through how you can use ultrasound dynamically, which again, I'm sure you're very much aware of. So when it comes to injection treatments, there's a number of options. So traditionally, steroids have been used. Hyaluronic acid is relatively newer. You can, of course, use both, and that's something that sometimes is neglected. And there are obviously other options as well, PRP being one, in the future, potentially stem cells and other kind of regenerative treatments. But that's outside the scope of today. So in terms of just simply pros and cons, hyaluronic acid versus steroid. Steroid has that traditional use. It's also relatively cheap. And it's very effective if you've got short-term inflammation or acute inflammation in that joint. It's very good at reducing inflammation and therefore controlling pain. And so that's helpful, particularly around the arthritic joints, but can also be very helpful post an injury. But it's only going to last for a short period of time, around 6 to 8 weeks. Whereas hyaluronic acid is much more about restoring the homeostasis of the joint. It increases the lubrication, but also provides shock absorption. So it's doing something completely different to steroid in that sense. In doing that, you're allowing the joint to move more naturally, but also encouraging the joint to look after itself into the future by hopefully promoting the production of more hyaluronic acid. It's also shown in different studies to last for much longer, closer to sort of 6 months in period of time. Now, and we look into some of the cons here of why you wouldn't use hyaluronic acid versus steroid. As with any injection, when you're introducing a needle through the skin, there's always a chance of carrying infection through. And obviously, you will hopefully use good aseptic no-touch technique, which you'd have learned from any training that you'll have done, and you'll have practiced, and you'll be documenting it and following good clinical procedures to hopefully reduce that risk. The risk of an infection within a joint is around about 1 in 10,000 from an injection. And therefore, the use of ultrasound guidance in the right hands should increase not just the accuracy of providing the injection, but also knowing that you're not going to damage associated structures and that you're only just passing your needle as far as you need to deliver the product that you're delivering. And again, that's the value of training and doing these things on a regular basis. So by doing that, you hopefully reduce that septic risk that may occur. And again, you've probably seen also the cons of steroids around, particularly sort of COVID-19, where you couldn't, if you remember back, you couldn't have it 2 weeks before or 2 weeks after either a COVID infection or exposure to a jab. And so therefore that reduced down the opportunity and use of it. Something that actually is coming back a little bit more recently. I just say that out of personal experience because we probably all dropped off a little bit in terms of asking those questions over the last few years, but there's definitely been an increase in COVID cases in the urban areas that I work over the last few months for sure. So that's definitely something that's sort of not to be forgotten, if you like. So I've sort of touched on this before as we've gone through, but essentially what is the purpose of injecting hyaluronic acid in arthritis or after injury? And the main thing is to return that homeostasis to the joint, because in doing so, that's going to be a pain relieving treatment. And so therefore you're restoring, hopefully, the ability for the joint to shock absorb, but also lubricating it and also nourishing what is a damaged joint. If we use the knee, think about the cartilage. By doing all of these things, you're helping to restore normal function. The quicker you can restore normal function, the quicker you can rehabilitate someone. So if we just think about that joint lubrication, shock absorption piece, and we move on to hyaluronic acid can either be low molecular weight or high molecular weight. So the low molecular weight hyaluronics are very good at providing lubrication to the joint because they're very viscous, they're very fluid-like. But that means that they're not very good shock absorption or shock absorbers. Whereas the high molecular weight ones, which are very viscous and therefore very thick when you inject, very hard, slower to inject, they're very good shock absorbers, but they're poor lubricants. If we remember going back to that slide with the red line and the blue line, what you want from a natural joint and from a more natural product is to be able to do both. However, there are potential advantages, therefore, if you've got someone who either wants to be moving a lot or not moving a lot when it comes to the choices you could use. So this is where understanding essentially the differences between the available products comes in, and therefore selecting a product that's going to be more appropriate for the patient that's sitting in front of you. So linear, cross-linked, and hybrid. And that's the way that hyaluronic acid is defined, if you like. So the linear products, exactly as they talk about, they're long straight chains of hyaluronic acid where there's not much cross-linking between them, okay? A more cross-linked product, again, gives you, it's thicker and therefore more viscous and therefore more of a shock absorber, whereas a hybrid product essentially has the ability to do two. So let's just look at that in a bit more detail. So if you think about the original Ostenil product, that has essentially straight lines of hyaluronic acid with not a lot of cross-linking between them. So it means that it's very good at lubricating, but you do need a couple of injections. And traditionally you talk about 3 injections in a short period of time, normally spaced out over 2 weeks. So a 4-week period to provide that for the joint. The cross-linked Durolane, which again has been around for a long period of time, is very good as a shock absorber. So more helpful if you're someone who maybe doesn't move so much, so more established arthritic change, so the early to mid changes that you might see. And then the hybrid, which we're going to talk a little bit more about in a while, has the ability to have multiple crosslinks. And that means that it can act when under low pressure at rest as a lubricant, but as you add load, it stiffens up because of the crosslinks, which allows it to also be a shock absorber. So where many people will look at hyaluronic acid and say, oh, they're all the same, there are actually quite key differences, and therefore making that correct decision for the patient that's in front of you will help with their rehab, but also their satisfaction from having the injection, which you've naturally recommended to them in the first place. So if we just look at synovial as a newer hyaluronic acid on the market, how does it compare to the others that are all available? And again, thank you for Kirsty for providing this. What you've got is much more concentration of hyaluronic acid at 3.2% compared to the more lower molecular weight hyaluronic acids, the more traditional ones, should we say. So you just use Ostenil plus there as an example. So that's around 2. This is 3.2. So significantly higher levels. And therefore, what the research has shown is that the research is only to 6 months, which is why they can quote 6 months. But at a 6-month point, you're still getting benefit from having had that injection, which is obviously significantly better than you would do from a steroid, but equally good research compared to the others on how long it sticks around and has some benefit. Now, the question is, how long does it stick around in the joint for? Because that's often a commonly asked question. There's not a lot of research on how long it sticks around in the actual joint for. It's quite hard to trace from what I understand. However, the value of doing these injections is to increase the natural homeostasis of the joint. And so therefore, what you're trying to do is get the joint itself to essentially increase its amount of synovial fluid and hyaluronic acid within that. And so that's partly where the benefit comes from. It's also, we talked about other injectable therapies that are out there for either injury or arthritis, and PRP being one, which can be combined with it. So thinking about what to use where, it comes in 2 sizes of syringe, a 1 ml and a 2 ml. And as with other providers of hyaluronic acid, you can use it not only just in the medium to large joints like the hip, knees, shoulders, and ankles, but also around tendons and the small joints of the wrist. Now, my experience generally has been with the 2 mil version, where I've done it mainly into the larger joints, mainly because of case presentations more than anything else, and therefore obviously the volume of what you see in clinic. Clearly, if you're more of a rheumatologist or seeing more tendons, then these smaller volume products would be more appropriate. So what's my experience of using synovial? So I've used it 25 times since March, mainly in knees. The age range fitting that sort of 25 to 55-year-old age group, where you've got sporty people who also are developing some early arthritic change, slightly more men than women. And the feedback that I've had from them when you follow them up 2 weeks after the injection is that it's been well tolerated. It was well tolerated on the day, and they found that they got on well with it a few days after. As with all these hyaluronic acids, they do take around 2 weeks to have a real effect as such. So you just have to make sure patients are aware of that. Whereas with a steroid, we compared it to previously, you can start to get an effect after a few days. Obviously, the main thing is that you're there to help to restore the function of that joint, and therefore you need to add in the physiotherapy, the conditioning work that goes with it. Now, as you probably are aware, hyaluronic acid has dropped off the insurance radar since August of last year, which means that we've moved more into that self-pay space for these injections in clinics. And certainly that's also something that's being seen in the NHS, which has been driven by NICE guidelines. The problem with NICE guidelines is that they're not necessarily based on everybody's experience, because where you're in a setting where you've got good support and a good MDT and you're able to get good quality physio into people and rehabilitation into people, you are going to get better results, which is why you see these sorts of products being used very regularly with athletic populations. You'll probably be aware of a number of people who used to work at Wimbledon for the tennis, and a lot of knee injuries in grass court tennis because of the surface and the way people slide, particularly having come off clay. And so injection therapies like this are very helpful in those environments. I've not seen any adverse reactions to people having this injection because of those reasons that we talked about before, where we've used good training and we're using good skin cleaning and onward management, etc., that goes with all these things. And I've just had one patient who was having regular hyaluronic acid by a different brand for his knees. He had 2 previously from me in the year before, so having them every 6 months. He wanted to try the difference, so did, but didn't find it was as good for him as the previous one he wanted to use. So he went back to it, which is completely fine. So I found it very interesting to use. I've used it in a variety of different settings with different people. It's been well tolerated. So in terms of next steps, one of the pushbacks on why hyaluronic acid isn't being widely used within insurance companies, etc., is how much UK-based research there is. Now, IPSA, for example, had provided 2.2 million injections worldwide last year. So there's a lot of data. However, I'm keen to help with the establishment of how effective this type of treatment can be, particularly when linked with good rehabilitation. As I say, there's differences between the sort of self-pay insurance and NHS markets and models. And that's where the Citius Retreats element of what I'm doing is looking at how we can put some research into this area. So with my background of working in high performance sport and within the military of settings around residential rehab, what we're looking to do is offer residential rehab weekends for people who have particularly ACLs, where you would have one of these types of injections a few weeks before you came. You then come in, have good quality physiotherapy, have a good physical assessment. We've got some pictures here of the use of force decks to give some good baseline assessments, and then taking people through whether they're early, mid, or end stage rehab on how to retrain, get back into physical activity. So linking the good work that was done in places like Headley Court and places like high performance sports environments where you can be very one-on-one and detailed, but taking people out of their day-to-day environment, immersing them for a few days in full-on rehabilitation, and using products like synovial to really help accelerate that rehabilitation so that they've got some good learning points they can then take back to the home environment to continue on. So that's a project that I've been working on for a number of years in the back of my mind, if you like, that we're now bringing to the fore. And it would be good to get that first one under our belt in November, with then a view to holding these on a regular basis in 2025. So number of references, and this is going to get shared with you at the end. So if you want to pick up on that, you can do. So now I just really ask you if you've got any questions for not just myself, but also Andy and for Kirsty, and we're happy to answer those now.
George, thank you very much for that. And yeah, those retreats look absolutely spectacular. So for anyone who doesn't follow George, he's one of the most connected and celebrity. He's always texting with new people that he's met. So yeah, very interesting guy. It's worth checking out his social media page. But no, I really appreciate your insights that you've shared there. Now, we've got some pre-submitted questions. Just before we go on to that, Kirsty's joined us now, who is clinical application specialist at IBSA. So Kirsty, how are you doing? Thank you for joining.
Yes, thanks. I've had some technical issues, but yeah, finally logged in. So yeah, thanks for having me.
No problem. Yeah, you're here now. That's the main thing. So we've got some questions that were pre-submitted, so I'll go through those now. So I'll leave it open to you guys to say who wants to go through them. So some of these were touched upon there. So I'll start off with Sandy Kosler, based in the Midlands, sports doctor. And so he's said for you, George, any preference on which HA to use? So we've talked about Ostenil Plus and Durolane. So I know it's well, can you give you a perspective on that?
Yeah, I mean, now that it's essentially off insurance, it then becomes more of a personal choice for individual patients because there's a cost point. A lot of these are now price point quite similarly to each other. Some people may have had experience before, some of them maybe not. As is the case, any sort of these newer products, different environments that you work in, offer them at different speeds, if you like, in terms of availability. So I think if you're looking at an even playing field where you've got all options available to you, I go back to those points I was trying to make through the course of it. It depends on what the patient is in front of you. I think for me, the majority of people that I'm seeing are young, fit and sporty. And that's sort of shown by those numbers. I was saying it's sort of 25 to 55 is the age group that I've used this product on. All of them have had, were happy with it, but one person wanted to go back to a different form, which is fine. But in general, it's been well tolerated in terms of when injecting at the time, and people have progressed their rehab on afterwards. So my view is that it's a very good product and that's been very helpful in the people that I've used it in. And I'd like to use it in more people. And hopefully that will happen now as it becomes more readily available across more clinics, etc. I think if people have already had an established regular use of a hyaluronic acid, as with same with many things, if you're used to using something, then you may well be happy with it. It just depends how much, what really it's probably which joint is affected, if you like. We're talking a hip or a knee or a shoulder or a tendon, and then how regularly you're needing to use it. So the more traditional products we talk about, like Symvis and Durolane, are very good from a shock absorption point of view, which people might like. But if you delve into it, they may find that they don't like the fact that it's not very, it's not very viscous. And so therefore, if they are trying to be more active, which a lot of the younger people are that I tend to see, or just want to be physically active, that they find that the one that has the ability for synovial to be both a lubricant and a shock absorber is an advantage for most people. So it's a bit of a non-answer that probably, because I've sort of said everything, but
no, that's okay.
I think it is just that, what's that person in front of you, and what's their goal? You know, what's their activity level? What do they want to get out of the injection? What's the value of doing it? Why are you here? Why are you wanting that injection? Understanding that helps to guide you on the path of what you're going to use. But you know, I've had really good results with it. I think it's just another thing that adds in. I think, you know, you come back in 2 years' time and see where the landscape is on the use of hyaluronic acid, and I think we'll see more people using it, particularly when you look at those numbers around what is the burden of OA and early OA in hips and knees, and where that's going as a journey.
I was just going to jump in there just to talk a little bit about the supporting research. There are some direct comparator studies looking at synovial HL compared to linear high molecular weight hyaluronic acid. And it outperforms that type of hyaluronic acid, but in particular in small joints, so in first CMC joints. And the feedback we've had anecdotally from patients who've used it early in this country is they get quite quick relief from pain with synovial HL, sorry. So yeah, the direct comparator studies there have been in first CMC joint OA, and synovial does perform better than steroids and high molecular weight HA in those studies.
Great, thank you very much. So for background as well, so Kirsty is an advanced physio practitioner and injector. So thank you for sharing that as well, Kirsty. So next question, this is a live one from D Stringer. So this is, can synovial be used in cervical degenerative disease?
Kirsty.
But we do have some case study reports that have been conducted with lumbar spine, facet joint OA, and synovial. Speaking from a practitioner perspective, hyaluronic acid is not routinely used for spinal conditions, and that is because they tend to be treating acute pain from nerve root impingement, and as such, the preference would be steroids in those cases. So yes, it would be clinical choice, but we don't have any supporting research to say that you could use synovial for cervical degenerative disc disease.
Okay, thank you. And then this may be another one for you, Kirsty. So do we know the half-life for synovial in the human knee joint?
We don't have any in vitro studies that shows the half-life. We're very outcome focused. Basically, we want to know what happens in vitro. So what we do see is, like George has alluded to, is by restoring the loss of hyaluronic acid through disease, age, or injury, you're encouraging the natural homeostatic mechanisms to kick in again, which keeps your synoviocytes and chondrocytes healthy long term. How long it actually lasts in the joint, we haven't measured that. What we do know is it does have that beneficial effect in restoring the homeostasis in vitro. In terms of clinical outcomes for patients, which is the most important thing, there is improvement in pain and function in all of our osteoarthritis studies to a minimum of 6 months. And that means they're not back to where they were at after 6 months. They still are improved at 6 months in both of those measures. We just haven't measured beyond that time period.
Perfect. Great. So next question, again, another live one from Nikki Pickford, good friend of ours based in Stockport. So she loves the look of your retreats, George, so that you might get some referrals there. So Nikki's a physio who treats a lot of ACLs in women's football. Is there a criteria for the research regarding patient selection and where they are in their rehab pathway?
No. In terms of when you would use it, you don't want to necessarily be using it straight away, because you've got to overcome the surgery. But this is used regularly in a lot of rehab around ACLs to keep that lubrication going, because clearly there's a big amount of trauma being caused, not just by the initial injury, but then by the controlled trauma that is surgery. And therefore, what you tend to find actually is that capsule becomes quite large, but also sort of chronically inflamed. And helping with the ongoing rehab is a very regular, this is a regular treatment for this kind of thing. Certainly in the athletes where they obviously have to load that joint quickly to get back and perform quicker than you're going to get from a normal everyday desk-based person. Again, this is a very helpful thing to allow sort of smooth recovery. And although, we talked there about it will last the joint research for 6 months, you can use these things more regularly than that. And as we talked about, it isn't something whereby you have the injection and bang, the next day you feel great about it. It does take, I describe it to patients as you've got a bell-shaped curve. You have the injection, there's gradual improvement, you then notice the effects, and then again, it will gradually tail off. And that will be different for different people. And particularly if you're starting to reload a joint, particularly a knee post-surgery, as you go through the rehab, this is a real, adjunct into that, into rehab and how you can really accelerate people through, but also then maintain them. So I see a lot of people down the line from their ACL many years later, and they want to keep good, knee function going. And this is a good way of achieving that.
Okay, great. This is a more general question, but is an MSK ultrasound scan the best first route for an acute or chronic injury versus digital X-ray?
Well, if you're suspecting a soft tissue injury, then ultrasound is, I would say, the most helpful thing to do, because it's painless. They're in the room, you can move them around, and you can look across all areas in terms of across surfaces and stuff. Obviously, an X-ray is only going to show you really the bone. Sometimes you may be suspecting, a fracture is a soft tissue injury with a broken bone in it, isn't it, after all? So you may be in many cases acutely potentially doing both, but it depends on how people present, where they're presenting, what kit you've got at the time, and how you're looking to protect and offload that joint or that area of concern.
Great, thank you. Then question regarding injections. So do they weaken the tendon?
They shouldn't be. And the reason I often find why people are asking that question is because they worry about whether the injection has purely gone into the tendon or has it gone into the tendon sheath. And that's again where ultrasound's helpful, because you want to be not injecting it into the tendon. It needs to go into the tendon sheath, around the tendon. So that's again where the advantage of having ultrasound guidance, so you know exactly where the needle is, you can see the needle, you can put it exactly where it needs to be, is the most important piece. And that's again why I go back to what I was saying before. You need to work within your scope of practice and regularly, be working on your CPD to ensure that you're up to holding good standards, because as is often the case with many of these things, there's various different techniques that can be used, and it's a technique that's got to work for you, but it's got to be reliable, it's got to be consistent, so that you're able to get good results.
Great. And then a question for you here, Kirsty. So how do you get prescribing authority for corticosteroids as a physiotherapist?
So there are two ways of prescribing corticosteroids as a physio. So if you work within an NHS environment, a lot of them have PGDs set up, which means there is an agreement as a service that appropriately trained physiotherapists who have an injection therapy module are permitted to administer corticosteroid injections under that patient group directive. If you don't work in the NHS and you don't have a PGD, the second way of doing it is through a PSD, where you would work with a prescriber directly. So that's usually a doctor, a GP, SEM consultant, orthopedic surgeon, and you go and speak to them and say, this person, I think, needs a steroid injection. Are you happy to do it under a PSD? And they say yes, and therefore they prescribe it and you can administer it under that. The third way of doing it is you become an independent prescriber, whereby you can do your own prescriptions, which is what I have. and you can prescribe based on your own clinical assessment for that person, and administer the medication appropriately. That wouldn't just be for injections, that would be for any medications within your scope of practice. Hyaluronic acid is a medical device, so you don't need to be a prescriber to provide hyaluronic acid injections unless they've been certified as a prescription-only medication, which in this country, I don't think we have any that would be classified as a POM. If you were to combine it with PRP, though, that would be a consideration. We have recently had our rights removed to be using PRP as a physiotherapist because the thought process is you potentially will change the makeup, even though it's your own blood that you're using to form the PRP. You are potentially changing the makeup of that blood, and therefore it is out of scope of practice of physios. So those are kind of the key things around injections. But yes, hyaluronic acid is a medical device, so you technically don't need to be a prescriber. You do need to be a trained injector, and we do recommend ultrasound guidance over landmarking. And the reason is because you don't have any systemic effect with hyaluronic acid like you would with a steroid. Therefore, you need to make sure that it's in the right place. And the second reason is it's a little bit more expensive to provide HA injections. So if you're not fully in the right place, you want to make sure that you're giving the patient essentially what they're paying for, because it's a lot of money to waste if you're not in the target joint or target area.
Great, thank you for that. I mean, that's something which we're seeing a lot now is, so we supply diagnostic ultrasound, and it's really exploded over the last 4 or 5 years. What's your view, George, on that happening? Because then we're looking at injections, and it's the private world is also, that's exploding with the challenges in the NHS. So it's a big question for you here, but like, where do you see that going, the private market, and where it's going, and for like, because there's a big opportunity for practitioners, but how do you go about navigating it safely and in the right way?
I think just to pick back on the point that Kirsty was making there around the product and whether it's classed as a device or whether it's a prescription-only medicine. As with all these things, if you're injecting it, you're responsible for making sure that it's been stored properly, that it is in date, and it is what it is. As with a lot of these things, you can buy from a number of sources, and I would always recommend buying it directly from the manufacturer so that you know that you're actually buying what you're buying. And then also making sure that you've got processes in place whereby it's being stored properly, so that it is exactly as the manufacturer intends it to be. You do see people getting into difficulty when they've not bought the brand version, they've not looked after it properly, and then they've injected it, unfortunately. So that's something to be aware of. What nobody wants to see is that the private medicine space, just because there's more availability of ultrasounds, that it's not being regulated. And that's where everyone who's involved with delivering ultrasound, whether that's either for diagnosis or for injection therapies, needs to be properly trained and properly accredited, have the right insurances in place, and also staying up to speed on their CPD. I know I've mentioned that a few times today, but that's really important because it doesn't take much for people to do it wrong, and potentially, make mistakes or cut corners, and then that affects the whole of the industry. And that's the thing that we don't want to see happen. And no one wouldn't want it to happen. I'm sure people, by being on this, on this talk tonight, want to make sure they're staying up to speed with what is good practice as well. So that's an important piece. I think, the fact that you can have an ultrasound in an outpatient setting, it's painless. There's no radiation involved. It's well tolerated by the patient, and particularly if we're looking at the arthritic population or even just an acute injury space, it's very, very helpful with diagnosis. I often talk to my patients around, look, we're doing this ultrasound because at the moment you're in quite a lot of pain with this particular joint. We'll use the knee again. What are we doing to protect that joint, offload it before we maybe go and do further investigations and further management? Do you need to be going to see a surgeon? Do you not need to be going to see a surgeon, for example? So look, it's ultimately, I think it's a good thing for everybody, whether you're in the NHS setting or you're in a private setting. But again, it's about working within that scope of practice, and also having, and within that scope of practice you could be an individual as a standalone practitioner in one clinic with one ultrasound machine, but having a good network of people to fall back on so that you can ask questions, I think is important as well. I think the more that I've gone on through my career, the more I probably ask questions than I probably did when I was, new. And the more that you have an opportunity to bounce things off people and see what their experience is, keeping a log of what you're doing and looking at what your results and your feedback is. I talked about the patients that I'd seen, using these injections and what the feedback was. And that's important because whether you're either just starting out or you're very well established and you're doing lots of these things and have done for a number of years, it's good to know, where you sit compared to others, and are you actually really getting the outcomes that you hope that you should get?
Right. No, thank you for that. Yeah, it's a really interesting time with everything. So that's why we've been putting on some of our own in-person events, doing more of these things. And I think it's really is speaking to people, attending webinars like this, and also ask us on things as well. Like we'd really love to help in terms of your understanding and what isn't within scope. So, but George, Kirsty, really appreciate your time on this evening. It's been great, and we're going to share all of the details. There's been some technical questions that have been asked, Kirsty, which I've monitored, which we'll forward on to you, and we'll answer those for everyone who's attended. But like I said before, we'll send you the link to our Academy page where this will go. But we'll also put the links into George's Citius receipts, which again is really, really impressive, as well as with IBSA. Great company. I was lucky enough to spend a weekend with them in Madrid at Isokinetic, which was really good. So yeah, it's really good, really exciting things ahead, and we look forward to seeing you on one of the next events we've got. But finally, thank you, George. Thank you, Kirsty.
Thank you very much, Andy.
Thanks, guys. Thank you for having us.
Have a good evening, everyone. Thank you.
Good evening. Thanks. Bye.
Bye-bye.